This meeting is being recorded for the minute-taking purposes, as well as posting of the recording of the proceedings on the agency's website. This meeting is also being live-streamed on the Access Health CT website, following a recommendation of an Access Health CT board member. We would like to thank the board chair for supporting this proposal, as well as our IT team and ID Lions for their implementation collaboration. Thank you.
Thank you, Marcin. It is requested that participants introduce themselves every time they speak. Roll call votes will be taken for every action item. Marcin, can you call the roll, please?
Yes. Charles Kleppel, Chair. Paul Philpott, Vice Chair.
Here.
Groen Ritter.
Here.
Dr. Dietrich Gifford. Dr. Gifford.
Present.
Thank you. Steven Hernandez. Matthew Brackman. Thomas McNeil. Mr. McNeil, I believe you joined us. You were on the call before. Mr. McNeil.
Tom, I think you are unmuted. You're muted, Tom. There we go.
We'll go back to Mr. McNeil. Andrea Barton Reeves, DSS Commissioner.
Here.
Thank you. Sean King, OHA.
Here.
Claudio Gualtieri, OPM.
Here.
Paul Lombardo from Connecticut Insurance Department.
Here.
Dr. Manisha Tutani, a DPH Commissioner.
Present.
Thank you. And Caroline Zambetti, designee for Nancy Navarrete, DMS Commissioner.
Good morning, present.
Good morning.
Steve Hernandez here, Marcin. Thank you.
Thank you. Thank you, Mr. Hernandez.
Matt Brockman's here. Hey, Marcin.
Thank you, Mr. Brackman.
That's it.
I believe that concludes our attendance list.
Thank you, Marcin. The chair requests that the Access Health senior leadership team introduce themselves at this time.
Good morning. This is James Michelle, the Chief Executive Officer for Access Health Connecticut.
Gina Walsh, Director of Operations, Access Health Connecticut.
Rebecca McClear, Director of Technical Operations and Analytics, Access Health Connecticut.
Good morning, Susan Rich-By, Director of Legal and Governmental Affairs, Access Health Connecticut.
Good morning, Caroline Ruette, Director of Marketing, Access Health Connecticut.
Good morning, John Carbone, Director of Small Group Product Development and Broker Support, Access Health Connecticut.
No, everything's fine here.
Good morning, everyone. Glenn Jurgen, Director of Human Resources with Access Health Connecticut.
Good morning, Tammy Hendricks, Director of Health Equity and Outreach, Access Health Connecticut.
And good morning, Janelle Maloney, Director of Information Technology.
I believe that concludes introductions of the members of the senior leadership team.
Thank you,
Mr. Chair, Vice Chair.
I appreciate that. Thank you. I'll turn this over now for a CEO report to James Michelle.
I just want to mention, Mr. Vice Chair, that no public comment has been submitted.
Pardon me. That's right. I've been informed, the board has been informed there is no public comment this morning. So now we'll go to James for a CEO report.
Thank you. Good morning, all. Again, as mentioned, I'm James Michelle, the Chief Executive Officer for Access Health Connecticut. Welcome to our September board meeting, and thank you for joining us. We have been working throughout the summer, preparing for our 11th open enrollment as we continue to work in collaboration with DSS and other state agencies to execute the strategy of Medicaid Unwind for the state of Connecticut for the last 6 months. And we will increase our momentum preparing for open enrollment as we head into the fall. I would like to welcome Sean King as the acting healthcare advocate. As many of you may be aware, Ted Doolittle is moved on from that position, and he's now a judge in the federal court system. Thank you, Sean, for joining us. Today's meeting is scheduled for 1 hour, and will consist of 2 major items. Number one, a review of the 2024 rates by the Department of Insurance and Insurance's Chief Actuary, Wanchin Chow. Then we will give you an update on our preparation for the open enrollment period coming up. Our 11th open enrollment coming up starting on November 1st. But first, let me give you a quick mention a few items before we get started. We are in the 6th month of the Medicaid unwinding process, and I want to share some enrollment numbers with you. 64.2% of Husky Health clients have renewed or re-enrolled in the Husky program. The Department of Social Services, the original forecast was for 76.9% renewal. 10.8% of that population have enrolled in a qualified health plan. We believe the reasons for the lower than expected Husky health enrollment numbers are that many people now have health insurance through their employers, have moved, have transitioned to Medicare. There may be other reasons as well. This fall, we will be conducting a leaver survey of those people affected by Medicaid unwinding who have not come back to re-enroll either in a qualified health plan or a Husky program. More to come on that. Again, the survey will start October, November, and we hope to have, and it'll be an ongoing survey, so we'll continue to give the board updates and as to why some folks have not come back to re-enroll. In a qualified health plan or a Husky program, and they have not re-enrolled, the survey will allow us to gather additional information as to why these individuals have not re-enrolled. And we've done them in the past, and the number one reason why people have not re-enrolled is because they have insurance through their employer. So again, more to come on that. If you have any additional questions, please, we are more than happy to answer them for you. And we have been sending out reports on a monthly basis to the board with respect to enrollment numbers. I just want to give a general overview of where we are as of this moment. But most importantly, the numbers are a little bit lower than expected, and we want to know why. We have some hypotheses as to why, but we want to confirm our thoughts. And the survey will certainly help us do that. And also the survey, we have applied for a grant to pay for the survey, and we are in the process of receiving that grant. So the survey will not be of any cost to Access Health as we move forward. Regarding our meeting today, we will begin with the strategy committee. I will give a brief update on the meeting from the strategy committee from last week. Then after that, Mr. Chow, the Chief Insurance Actuary and Assistant Deputy Commissioner of the Connecticut Insurance Department, will give an update on the 2024 rate review. Then after that, Katie Hearns, our Associate Director of the Enterprise Project Management Office, will provide an open enrollment 11 readiness review overview. Again, she will cover our technology changes that are in place and some of the risks associated with that, and also a marketing and outreach update as well. And again, as we prepare. And then, if time permits, Caroline Ruette, Director of Marketing, will give a review of Medicaid Unwind, and Susan Richby, Director of Legal Government Affairs, will conclude the meeting with a legal policy update on the Affordable Care Act. Again, this is if time permits. There are a few votes we will be asked to take today on committee membership that would follow my update. It's exciting to have some new members join us, but I'll be remiss not to call out the dedication and years of service by two departing board members. Thank you to C.C. Woods, who joined the board in July of 2011. So she was one of the original board members before Access Health existed. And thank you to Ted Doolittle, who joined the board in February of 2017. They both have made significant contribution to our growth and success, and we wish both of them well as they move on to their next phase of their lives and careers. Thank you very much, Mr. Chairman. This concludes my brief report.
Thank you, James. The next order of business is approval of the June 22nd, 2023 special meeting of the board. And prior to entertaining a motion, are there any questions from the board? There being none, I'll entertain a motion to approve.
So moved.
Second, this is Gifford.
Okay, moved in second. Marcin, do you want to call the roll?
Mr. Chair, is there a discussion on the motion before us?
I didn't hear any questions from the board. Are there any questions or discussion from the board?
There are no questions.
No questions. Then let's go ahead and can we take that moved and seconded that we already have?
Yes.
Okay, all right. Call the roll, please.
Charles Klippel, Paul Philpott,
Yes.
Grant Ritter,
Yes.
Dietrich Gifford,
Aye.
Stephen Hernandez,
Yes.
Matthew Brackman,
Yes.
Thomas McNeil. Mr. McNeil. Andrea Barton Reeves. Sean King
Yes.
and Claudio Gautier.
Yes.
Thank you.
Motion passes.
Motion passes. Thank you. We have another set of vote related to committee assignments, and Susan Richby has a preamble about it for us. Susan?
Yep. Thank you, Mr. Vice Chair. The bylaws, as we talked about before, require that the board appoint and remove members to the standing committees, the 4 standing board committees, the advisory committees, and any other ad hoc committees that the board may form. So as James mentioned today, we've noted that Cecilia Woods and Ted Doolittle have stepped down from either the board or their role that put them on the board. And we also had Kevin Galvin, who's been a member of the advisory committees for a long time, has requested to step down as well for his work commitments. And we also, as James mentioned, Sean King is now joining us as the acting healthcare advocate. So we have a series of votes to either remove members from committees and also to add Sean King to an advisory committee. And there's some other members that are being removed from some of the advisory committees. And these are members that have not attended meetings or been active on these committees for several years. So I will turn it over to you for any questions or the votes. Thank you.
Okay. Are there any questions from the board of Susan?
Hello, this is Grant. I have a question about the my favorite committee, the Health Plans, Benefit and Qualifications Advisory Committee. Ted Doolittle was a very active member of that. Are we considering appointing Sean King to that committee as well?
Grant, yes.
Okay.
Sean King will replace Ted in that committee.
Thank you.
Okay. So I've been advised by Susan that we can vote on these as one grand motion. So I'm going to read all of these changes and then we'll go from there. Remove Cecilia Woods from the Audit and Strategy Committees and the Health Equity, Outreach, and Consumer Experience Advisory Committee. Remove members from the Small Business Health Options Shop Advisory Committee. Lynn Marie Janzik, Marta McCuba, Nathan Field, Patricia Polciano, Kevin Galvin. Remove members from the Health Plans, Benefit and Qualifications Advisory Committee, Theodore Doolittle, Margarita Giuliano, and Maria Diaz. Remove members from the Health Equity, Outreach, and Consumer Experience Advisory Committee, Theodore Doolittle and Karen Siegel. Remove Theodore Little from the Human Resources and Strategy Committees and appoint Sean King to the Health Equity, Outreach, and Consumer Experience Advisory Committee. So those are the proposed changes. Are there any questions from the board?
I have a question or addition to add. It was just mentioned or requested that I be added also to the health plan. I'm sorry, this is Sean King. That I be added to the Health Plan Benefits and Qualifications Advisory Committee as well. Happy to serve if that is the rest of the board's pleasure. So if you want to add that as well.
Yeah, sure. That committee gets active in January. So we were waiting to debrief with you. But that's fine. We could do it now. But we were going to do it in the future meeting. But if you want to do it now, if the board is open to agreeable to that, we certainly could add you to this vote as well. I guess we want to have a conversation with you first before we added you to the to a vote for it. But if you are comfortable with it, absolutely we could do it now. Susan, is that?
Yeah, that's fine. That would be if somebody wants to make probably better for someone else to do it than Sean. Someone else wants to ask for an amendment to the motion that Paul just called. So it would be to appoint Sean King to Health Equity and also to Health Plan Benefits and Qualifications Advisory Committee.
Yeah, hi, this is Grant again. I'd be happy to make the motion to add Sean King to the Health Plan Benefits and Qualification Advisory Committee, which I serve on.
Thank you.
Can we vote on that amendment at the same time then?
Yes. You just vote on it as amended.
Okay, as amended. All right. Chair will entertain a motion to approve as amended.
So if somebody wants to.
I move as amended.
And just move for all of these various motions.
All the motions that are listed on that slide, plus the amendment that Sean King be placed on the Health Benefit Plan Review Committee.
Thank you.
Hi, this is Grant. I'll make that motion to move forward all these plus the amendment.
Second. Do I hear a second?
I'll second it. It's Gifford.
Thank you. Marson, you want to call the roll?
Yes, Mr. Chair. Charles Claypool, Paul Philpott,
Yes.
Grant Ritter,
Yes.
Deidre Gifford.
Aye.
Thank you. Steve Hernandez,
Yes.
Matthew Brackman,
Yes.
Thomas McNeil, Mr. McNeil, Andrea Barton Reeves,
Yes.
Sean King,
Yes.
and Claudio Gualtieri.
Yes.
Thank you.
Okay, so the motion passes. Next order of business is a committee update from James Michelle.
Good morning, all. Again, a very brief update on our strategy committee. We met last week with Chairman Stephen Hernandez. The one item we discussed, and that is still evolving, that is that Charlie and I had a conversation after the board meeting in June, in that create an ad hoc committee to look at the revenue streams for Access Health going forward. And this we're calling it the Access Health Committee, CT Sustainability Committee. Again, we're going to look what other revenue streams that are that Access Health could take advantage of. Now, the staff, we have been working on this continuously, but I suggested to Charlie that it might be helpful to have a subcommittee of the strategy committee to work with us as we explore these. And so when we bring them to the board, and it won't be a surprise to the board. So more to come on that. Charlie and I have talked about potential committee members. And I've spoken with several of them, but we have one or two more that I need to talk with. So look forward to bringing to the strategy committee next month's meeting, ultimately to the board in October or November, let's get this committee started and running. The committee will be working with me, John Carbone, and our Director of Finance. And we'll bring in other leaders of the organization as needed. Again, we will try to keep the committee as small as possible, as many of our leaders are very quite busy with preparation and execution of OE11, open enrollment, as well as continued support for Medicaid unwinding. So I'm trying to limit the amount of people that we tied up with extra work. But as we need additional leaders of the organization or other staff, we will pull them in as needed. I want to get, and we discussed this with, at the Strategy Committee last week. It got a lot of support. The intent here is to explore new potential revenue streams for Access Health in the light that our assessment dollars continue to shrink on a year-to-year basis. What other avenues are available to us to support our operation to minimize us having to ask for another increase to the assessment in a way out future. So again, Mr. Chairman, Mr. Vice Chair, this concludes my quick committee update, but more to come on the ad hoc sustainability committee in the coming months.
Thank you, James. Any questions from the board? There being none, the next order of business is a presentation from the Connecticut Insurance Department related to the 2024 rate review. And that will be done by Mr. Wanchen Chow from the CID.
Thank you, Chairman, and good morning, everyone. I'm the Chief Actuary and Assistant. Can you hear me? Sorry.
Yes.
Okay. So, yeah, I'm the Chief Actuary and Assistant Deputy Commissioner, working with Paul Lombardo and our actuary in reviewing the rate filing this year. It's my honor to report the 2024 rate review on behalf of Department of Insurance. Next slide, please. And on the next several slides, I will discuss the scope of review, the key factor impact the 2024 rate increase, and the brief summary of the rate increase by companies. Please feel free to ask questions. And for the scope of review, this year we have 10 rate filing on individual and small group, and with approximate 188,000 cover life in Connecticut, and that's from 9 companies. Next slide, please. For the next 2 slides, I will discuss the key factor for this year's review, and they are the annual trend, and then I will also touch on the experience adjustment, some of the new legislation impact, and then the Medicaid unwinding. From the annual trend, that's mostly for medical inflation trend, is a factor that accounts for rising healthcare costs, including the cost of prescription drugs, the increased demand for medical service, and the severity of future claims. Health insurance premiums are affected by several key factors. Medical costs have surged by 7 to 9%, and prescription expense have risen by approximately 11 to 19%. This increase are primarily driven by higher healthcare utilization and greater disease severity, which lead to advanced stage treatment and an overall increase in health care spending. And for this year, we definitely also consider the benchmark cost trend by OHS in our reviewing process. Next slide, please. And this slide will touch another 3 other factors. One is the experience adjustment. Experience adjustment is necessary to reflect deteriorating claim experience from the prior rating period to the current rating period. And for the legislation, the impact of bill passed, such as Public Aid 22-90, which deal with breast cancer screening, to extend the insurance coverage, and 2247 deal with children's mental health and coverage for 2 mental health wellness examination per year. And the last one on the slide is the Medicaid unwinding, the impact on the current commercial market due to Medicaid unwinding. And so there's a potential worse loss cost because the market shifting. Next slide, please. So for the next 4 slides, I will have a brief summary of the rate increase by company. And for the on exchange first, they are individual from Anthem and Connecticut. And then for the small group, it's only Anthem. And then for the off exchange, we will discuss individual and then small group by Aetna, Cigna, and United Care companies. So for the on exchange individual, the first one you see here is the Anthem Health Plan. And they asked for 9.8% average increase with a range between 6.8 to 13.6%. And we approve 5.6% with a range between 1.1 to 11.3%. And this has 33,939 cover life. And then for Connecticut Benefit Inc., they asked for 12.7% with a range between 10.2 to 15.5%. And we approve 10.3% with a range between 7.9 to 13%. And the cover life is 64,482. And for Connecticut Insurance Company Inc., they asked for 17.5 with a range between 10.2 to 22.2%. And we approve 15.3% with a range between 8.2 to 20%. This is for 11,954 cover life. Next slide, please. And for the small group, we have answered this here. They asked for 14.9% with a range between 8.9 to 22.1%. And we approve 5.1% between 0% to 11.7% for the 27,565 life. And for the Anthem Health, the Anthem company, they offer the both the individual and small group, and they offer that for both the on exchange and off exchange. For individual, Anthem has the number there for cover life is 91.8% is on exchange. And for the small group here, out of this 27,565, 3.3% is on exchange and the other is off exchange. And when they offer this, if they are the same plan, then the rates are the same. Next slide, please. So for the off exchange, the individual, and we have Connecticut Inc., which is HMO, and they asked for 15.4% with a range between 14.9 to 16%, and we approve 12.3% with a range between 11.8 to 12.9% for 1539 cover life. Next slide. And this slide was for is for the off exchange small group, and we have the right here for Aetna, Cigna, and then Oxford, 3 United Health company. And for Aetna, they asked for 10.9% with a cover life of 105. And so without enough justification and the low credibility, we reject their request. So we approve 0%. For Cigna Health and Life Insurance Company, they asked for 23.04% with a range between 20.6 to 25.9%. And we approve 13.8%. with a range between 11.3 to 17.6% for 2599 cover life. For Oxford Health Plan Inc., they asked for 7.5% with a range between 4.5 to 10.1%, and we approve 4.1% with a range between 0.8 to 6.6% for 1483 cover life. And for Oxford Health Insurance Inc., they asked for 8.5% with a range between 4.2 to 11.6%, and we approve 5.1% with a range between 0.9 to 8.1% for 2415A cover life. For United Healthcare Insurance Company, they asked for 8.2% with a range between 1.2 to 14.7%, and we approve 4.8% with a range between -2 to 11% for 1920 cover life. And that's the end of my slides presentation. I'm happy to take any question.
Thank you. Are there questions from the board?
Mr. Chair, Mr. Vice Chair, there are two questions, Dr. Gifford and Mr. Sean King.
Sean, you got a question?
I think Dr. Gifford had her hand raised first. If
I'm sorry, Dr. Gifford.
Please, I defer to the newest member of the board, Sean.
That's fine. I'll accept that. Is there any way that you can? So I presume that the insurance department's decision to reduce some of these requests is based on a combination of the plans overstating their price trends, their utilization trends, their morbidity, those types of things. Is there any way you can give us a sense of which of those factors contributed more to the department's decision to reduce these rates? Also just mentioning that I recognize the department also limited for these plans their requested profit margins as well. So that if you could give us a sense of how those different factors contributed to the department's overall reduction in these rates. Hope I articulated that question well.
Yeah, thank you, Sean. That's a very good question. And I think we talked about the medical costs have surged by 7 to 9%, and those are one of the key factors. And then also the prescription expense increased by about 11 to 19%. So those two I would count as the most important factor to impact this kind of health cost trend. And I saw Paul has been in this department and working on this subject. So Paul, do you want to add anything else?
Yeah, Sean, those factors would impact different companies in different ways. We have a disposition, and you're well aware of that. We have dispositions that are on our website for each of the rate filings that goes into much more detail, specifically on each filing, what was adjusted, because they do vary from company to company and from filing to filing as to specifically exactly what was adjusted for each of the companies to generate those lower increases. The 75 basis point limitation on the profit was across the board to every filing, and that was applicable to carriers that exceeded the 75 basis point profit. There were carriers that with their original submissions were below that, so their profit margin was not impacted by that cap. I hope that answers your question.
It does. I appreciate that context. I just I wasn't sure if there was some overall trend across all the carriers as to which of those factors they might have tended to overstate more than others. But we'll digest the filings, the dispositions themselves, just to try to glean more information from that. Thank you.
Yeah.
Dr. Gifford.
Thank you. And thank you for the overview of the final results. I'll just observe the obvious, which is that we have a very, very long way to go to these rate increases being even approaching what has been set as the cost growth benchmark. So if in fact utilization is increasing, as you state the plans are asserting, then price increases are going to have to be even less than the benchmark rate in order for us to, as a state, meet the benchmark. So we have a challenge before us since the benchmark is at around 3% going forward. I wanted to ask about the impact of the Medicaid unwind because I struggled at the informational session. I struggled to understand the rationale that the plans were presenting as to why the Medicaid unwind was going to increase their costs. As you know, there are no copays or coinsurance in Husky. So this induced demand, or whatever the term is that they use for, people seeking more services once they get commercial insurance, I didn't really buy. Can you explain why the Medicaid unwind contributes to increased costs?
Yes, Dr. Kim, this is a very good question because the Medicaid unwind itself, since it's, the time period has been expired, so some of the potential Medicaid unwind will be ineligible for this coming year. And so when they convert to our healthcare provider this year, the potential is they will have the worst loss cost than the average insured in our own exchange market here, on our off exchange market. And so it's the worst loss cost P by P, the health cost that will impact ours. And I hope, that address some of your question, but I know if you are looking for some more detail, please discuss that.
I didn't quite catch the rationale. That would it be they assert there will be increased utilization, or that the Medicaid population is more sick, or some combination of the two?
I would say it's the Medicare population are different from the average population in the market. And so I cannot say they are most, they could potentially, they are sicker than the average population. And the utilization, I cannot say that. And Paul, if you have any more detail to.
Yeah, the first thing, Dr. Gifford, is that some of the carriers priced for this, not all of them. That's the first thing. The second thing is that some of the impact was lessened. I think the maximum allowed load for Medicaid unwind was 50 basis points in the pricing. I think it was a combination of not knowing what that population that would be entering the commercial market would bring to the commercial market, and the inability for companies to change their rates for 2024 once the Medicaid unwind was completed had a lot to do with the potential impact of the individuals that were coming into the commercial market, either re-entering the commercial market or coming into the commercial market for the first time. So I think all of those items attributed to the fact that there's an unknown there of what those individuals would bring into the market, and their inability to affect price once these prices were set for 2024.
Okay. I will go on the record as being skeptical that the high utilizers in Medicaid tend to be those qualified through their disability and dual eligibles unlikely to be switching off of Husky into the commercial market. And the vast majority are going to be young, working age, very low utilizing population and or kids. So, but to your point, Paul, it sounds like it didn't make a huge impact on the rates.
No, it
overall.
was limited. Yeah, it was limited. Yep.
Thank you.
That's correct. You're welcome.
Any other questions? Okay,
I believe Dr. Ritter, I believe Dr. Ritter and Commissioner Reeves.
Okay.
Okay.
Yeah. Hi.
Grant?
Could you go into detail, a little more detail about what deteriorating claims experience really means, as opposed to medical trend? I mean, how is it distinguished from medical trend?
Can you say again? Sorry.
One of your cost drivers, was deteriorating claims experience. Could you go into more detail about what that really means?
Okay. So basically, when we review the rating plan for every year, and we look at their experience, and so when they have the deteriorating claim experience, that means one or the other carrier, those experience are worse than their expected plan there, and so they reflect that in their kind of red filing supporting material there, and that's what we use for that reason. And Paul, do you have anything additional you want to add?
Yeah, I'll try to explain it, Grant, in general terms. If when we approve the rates for 2023, let's say the rate that it was approved was $100 and the expected claims were $80 for 2023. So their pricing is set at a certain level. It's $100. Their experience comes in and they have to take the experience from 2022 and they have to trend it forward to 2024. Okay, so their experience may trend well above the $80 that supported the $100 premium in 2023. So you're starting from a premium point from 2023 to change it to 2024. You're starting from a claim experience period of 2022. So deteriorating experience would mean that your claims came in more excessive than you anticipated and that your current premium in 2023 supports. And so just to get back to where you need to be, your starting point, you have to account for that claim differential because your existing premium doesn't support that. And then the trend is completely separate and distinct. That's what you project your costs to be in 2024.
Okay. All right. So it's got to do with 2022 being 2 years past rather than just 1 year past. Okay.
And it being worse than anticipated and expected, and that was the build for the 2023 premium.
Okay. Okay.
Yeah.
Thank you very much.
Yeah.
To just kind of a summary on that is the actuarial practice from all the ASAP we use is kind of the actual use the past statistic and then to forecast for the future rate. And so sometimes the actual versus is expected are different, then they will be reflect accordingly. So hopefully that's helpful.
Okay. Yes. Thank you.
Any other questions?
Yes, I have a question. This is Commissioner Reeves. I do have a question. I have
Go ahead,
two.
Commissioner.
Thank you. My first question to CID is that we would be at DSS be very interested in seeing whatever data, evidence, or support that the insurers provided to support their assertion that those on Medicaid moving off during unwinding have higher utilization or are sicker to justify the rate increases. We would very much like to see that data if it's available. And second, I would very much like to understand the relationship between the covered lives and the average request of the increases that the insurers have asked for.
Thank you, Commissioner, and those are good questions. And to answer your first question about this Medicaid unwinding itself, and that's why when Paul talking about this kind of impact this year is not as material, because we like to see the actual experience, how that kind of from the Medicaid to the commercial market. And so that's why this year we limit kind of the percentage they claim they should be. And coming year, when we see the actual experience, then we can definitely share that with you and all this detail. If you even want to look at these years, all these rate filing are available. And for your second question, you were talking about the detailed review of the rate filing. Again, that's the all available in our SURF system. And if you like to have that, please let us know if there are any specific company you'd like to see the detail, or you'd like to see every of them, and we are very happy to work with you on that. Paul,
So I just want to make sure that I understand. So the insurers engaged in an analysis of the comparison of those who are on Medicaid as compared to those that are not in their current market, and they presented that to you, and that data is available?
Their support, Commissioner Reeves, is contained within their rate filing, which is public information. And our back and forth communication is also available. It's posted on our website. So the initial support for a Medicaid unwind load was included in their original filings that are available to view. Our correspondence back to them, if we had questions around their support for the unwind factor, are also available, and their responses to those questions are available as well. All of that's available on our website.
Okay, thank you.
Yeah, Commissioner Reeve, and so when you want to ask the detail, and definitely those are information available, but if you can separate by which company you are most interested in looking at, because we have two actually, Tricia and Sarah, review all the rate filing this year with Paul and myself. And so if you are interested in looking the detail for some specific company, if you can share that with us, then we can definitely have a more detailed discussion with you accordingly.
All right.
Thank you.
Yeah, I will be submitting a request for that information. And my second question was the relationship between covered lives and the average requests that were made. Is there any relationship at all?
Definitely, and that's why we said the coverage life and depends on the approved rating plan, because the insurance carrier they cover life is by different plan they have. Say for Anthem itself, they might have 5-6 plan for the off exchange for individual, and so it depends on the cover life in the different type of the individual plan they have, and then the rate change impact. And so that's how we calculate is the average rate based on that weighted average, and depends on the individual rate change request percentage between range there. Does that answer your question?
It does. Thank you.
Thank you.
Okay, I've got one question, and that is that my concern is that the ongoing relatively high rate increases is due to some type of larger systemic thing, and that is that I see where the block of business is now at 188,000 lives. I think if you looked at this thing 5-6 years ago, it'd probably be more than twice that number. And so obviously the block of business has decreased substantially over time. And a lot of that has been due to lives leaving the fully insured pool and going to a self-funded or partially self-funded type product. And there's no doubt in my mind that there's some anti-selection involved there. So we're losing the healthier lives And I'm wondering if you believe that there's some anti-selection involved in terms of why these rate increases or why the utilization is higher, if that is indeed the case. And if there's anything really that we can do about it.
Okay, thank you for that question. I think this is the important question, and for us, all of us together to collaborate, to work together, because this called the, when you say the anti-selection subject, that's a possibility. That's a possibility, and because when we work together for this health product, even we try to clamp down this kind of rate request, but there is a key issue is the availability and affordability issue. And so we need to kind of have the balance, the balance effect on those two in order to address this. And that probably not just the Department of the Insurance, also include all the hospital system, etc., to see how we work together on that. And so I cannot say the anti-selection is the only factor for that, but probably do have some effect. And Paul, you want to add anything?
Sure. Paul, that would explain a little bit about what's going on in the small group market. That would not explain the continued significant premium increases in the individual market.
Right.
There clearly has been a significant reduction. About 5 years ago, we had about 270,000 covered lives in the small group market. It's just south of 100,000 lives now. So clearly the small employer level funded products have increased significantly over time. As far as what we can do, I can tell you that the New York regulatory environment is they do not allow stop loss plans to be sold or available to the small group market in New York. They still have significant increases from year to year, similar, slightly lower or slightly higher than Connecticut. So I'm not sure the answer is strictly that small employers are moving to level funded plans, because they're not allowed to do that in the New York market. And the New York market is still seeing significant premium increases of the magnitude that we are seeing in Connecticut. So I do believe, and I think we all believe and understand, the underlying healthcare delivery system in our state, the cost structure, the utilization of services, and the prescription drug, both cost and utilization of prescription drugs, accounts for the majority of the reason why we continue to see health insurance premiums increase at the rate we do see them in Connecticut.
Yeah, thanks, Paul. It is a vexing problem because, for one thing, at Access Health, we have thousands of our members that pay 100% of the premium. Not everybody that comes through Access Health gets a subsidy. And so for the folks that are paying 100%, I mean, when you get a 10-15% plus rate increase every year, it could be talk about vexing. It could be awfully vexing. But anyway, I feel like we've got a responsibility there. I don't know what the answer is. We're not certainly not going to solve it here in the next couple of minutes. But James, maybe this is something we could put on the table for some committee work or whatever you suggest.
Paul,
Okay.
Paul, Paul, that's one of the areas that we're going to focus on: revenue opportunities. How do we options available to us, especially to Paul Lombardo's comment? How do we respond to the shrinking pool of assessment revenues from the small group marketplace?
Yeah. So this thing's got a lot of tentacles, and the assessment's one of them, and premium increases is the other, in my view. So, but anyway, okay. Thanks for the presentation and some great questions. And I think we've got time, James, for a open and readiness update. Do you agree?
Yes, absolutely. I'm going to ask Katie Hearn to give you a quick overview of where we are. I need the board to know that we do have a plan that we're executing, and we are on track to be ready for November 1st, 2023. However, we do have some risk that we are tracking, and notably, as Katie's going to inform the board, we are transitioning from Deloitte to a new vendor to provide operational support. It's very risky in that something always goes wrong doing open enrollment. So we want to make sure that this new vendor is ready and able to support us as things move forward. But go ahead, Katie. Just very quickly, because we only have 3 minutes left, if you don't mind.
Yes, thank you, James. Thank you, Chairman. Good morning. I'll try to be mindful of the time. I'm Katie Hearn. I'm the Associate Director of the Enterprise Project Management Office at Access Health, also called the EPMO. We're managing more than 20 projects currently. We're focusing our attention on open enrollment right now. We do expect that to run from November 1st through January 15th. And I have some technology, marketing, and outreach items to just quickly share with you. So as James mentioned, Infosys will be taking over our maintenance and operations of the HICS system, of our application system, for the first time. Previously, Deloitte did that. Deloitte will continue to do our system releases, so any enhancements or changes to the system is still Deloitte's domain, but running batch jobs like auto renewals and things like that, that is what Infosys will be doing for the first time this OE11. So we're monitoring that closely. My department has 2 project managers managing OE this year to help support that transition. In addition to that, we're going to have our dental enrollments processed through the HICS system this year for the first time. When we moved standalone dental plans to the HICS system, we saw an increase in dental enrollments that was significant. So we think that now having the auto renewal process in place for dental in HICS will help with our enrollee retention. We're also going to connect HICS with the National Change of Address Data Service from the U.S. Post Office. This will inform us of those who have about new addresses for people who have recently moved, and this will help to cut down on what is sometimes a high volume of return mail. And the next slide, please. I have a marketing overview to share. Caroline Rouette, who's the Director of Marketing, will be able to share more details at future meetings with you. Just very briefly, I wanted to point out that currently the marketing department is looking at all the feedback that was received from 6 focus groups, and they're looking to incorporate that into the overall marketing strategy. The uninsured, underinsured, subsidized, and unsubsidized populations were interviewed, along with Spanish language speakers in the greater Hartford and greater Fairfield areas. In addition to that, marketing is creating new collateral to share with our health equity and outreach team for distribution. That gets shared with our community partners and is available to Connecticut residents. Also, every year we update the accesshealthct.com website with new information. There are brand new blog posts this year and updates to our toolkits for community partners and the public. And also our advertising campaign and our media plan are underway. There will be TV, radio, print, digital, and out-of-home ads. Out-of-home includes billboards and advertisements in public transit areas and things like that. We're excited that we're going to have on-location footage right in Hartford and New Haven for the TV ads this year. And also, for health equity and outreach, we have our virtual healthy chats scheduled. One was just yesterday. Another is scheduled for October 18th. This is an informational session open to the public. In addition to that, we have community partner Zoom meetings scheduled the first Thursday of every month. This gives our certified application counselors a chance to ask questions of Access Health. And Outreach is also working on a lot of in-person help opportunities for OE this year. 20 fairs are planned throughout the state of Connecticut between November and January. The annual community conference is in person this year, which is great. That's October 11th. And our 4 navigator organizations are still with us in the Bridgeport, New Haven, and Hartford areas. And we will have ongoing enrollment assistance for anyone who needs it during open enrollment at the East Hartford and Stamford Public Libraries. Thank you.
Thank you, Katie. That was a very quick right now. Again, the board has the presentation, because if you have any questions, I strongly encourage you to reach out to me, and I'll respond to them as quickly as possible. Mr. Chairman, this concludes our presentation that we intended to present to the board. The others were extras if we had time, and we've run out of time, but we are more than happy to continue. But I know a lot of board members have hard stops at 10 o'clock, so we don't want to encroach on their calendars unnecessarily.
Right. We already appreciate their forbearance, right? Okay,
Yes.
so with that, if there's nothing for the good of the order, we'll entertain a motion to adjourn. Do I hear a motion to adjourn?
So moved. This is Sean.
Thank you.
Seconded. This is Grant.
Thanks, Grant.
Roll call,
Martin?
Charles Klippel, Paul Philpott,
Yes.
Crown Ritter,
Yes.
Deidre Gifford, Dr. Gifford, Steve Hernandez,
Yes.
Matthew Brackman, Thomas McNeil,
Yes.
Andrew Barton Reeves,
Yes.
Sean King,
Yes.
and Claudio Gautieri. Thank you. We did receive 6 voting members' votes. Thank you.
Okay, thank you for your attendance. We
Thank you all
appreciate
very
your
much.
participation. And the meeting is adjourned.
Thank you.
Thank you all. Have a great day.
Bye now.
Thank you.
Bye, everybody.
Thanks, folks.
Bye, folks.